So let's just start with the AUA guidelines that Suzette touched on, and this fact that they were updated in 2023. And for me, as just a community private urologist, I think the first one I look to is degree of bother. It's the third question I asked. Are you bothered by leakage when you cough, jump, laugh? Because a lot of ladies were like, yeah, I have a little bit of that, but I'm not that bothered. So we're here to treat and improve things that bother women and men with stress incontinence. I only treat women right now. And then second point is we always need to, in this day and age, slings have been around since 1998, but informed consent's very important, and it's only growing more and more important in shared decision-making for quality of life issues in patients. So discussing the risk of treatments and alternatives to a mesh sling. I can't tell you how many women walk into my office and they said, well, what's this bulking thing? I saw 4 urologists, no one even mentioned it. So they're just excited that there's perhaps a middle ground to discuss in informed shared decision-making. Okay, so you already saw this, but I just want to point out a few things, once again at the top. Availability of options. So I'm all about patient clinical care pathways, huge believer for overactive bladder. The more you offer, the more buy-in you have, the better adherence, the less attrition over time in these leaky patients. And so the more you have on your menu, I feel the more you'll get treatment to these patients. But once again, discussing complication and risk for each of these therapy options. I'm gonna kind of bag on the updated AUA guideline here, where I really feel bulking agents should be between non-surgical and surgical, procedural. You can do this in the office. Stop calling it surgery. It's a procedure. Kelly's laughing. Yeah, So I think we're doing a disservice by not having this in the middle. Just like UroLift, you can offer it in the office. And this concept of procedure, you really get more patient buy-in. You get more, yes, I'll try that. Once again, the arrow on the right side, it's very redundant, but we have these mesh slings, they work great. You must disclose risk and that there are alternatives to it. Special cases. So for me, I think bulking agents have really been very useful in special cases. Number one, that stovepipe urethra after someone had been pulled up excessively with a sacrocolpopexy, where you're a little nervous about doing a sling in that patient. I think a bulking agent is a great option. Nicole Fleischman, when she does all of her sacrocolpopexies now, she's almost prophylactically doing a bulking agent at the same time for these patients. Neurogenic bladder. Yeah, I get very nervous about DHIC and a sling and shooting these patients into poor emptying and retention, which, as all of us know, after sling, when you have a patient who can't empty well, they are not happy. It's a tough patient to deal with. And then I get really excited with childbearing. I'm like, well, yeah, I'm actually comfortable doing a bulking agent, like between kids. I'm okay with that. I don't think we're burning any bridges. Diabetes, a little scary at times to put a sling in that patient if they have a high A1C. Ooh, obesity. There's some big vet medicine patients out there where you're like, I'm really nervous about, throwing a trocar in this patient. And then older patients. I think bulking agents, potentially great offering in those patients. Okay, so back to the guidelines. Let's see. So I feel the guidelines got just a lot more forgiving for bulking agents with the update in 2023. It's a viable option. We avoid a more invasive option. Patients don't like invasive surgeries for quality of life issues. And we avoid a recovery time. On average, data states we keep patients down for 6 weeks. We practice, most of us here in Colorado. Women do not want to be down for 6 weeks. Like the CrossFitters, they don't want to be down for a day. And when you can say, hey, worst case scenario, you'll have a catheter overnight, you need a driver or sedative if you're doing sedative, you can go back to the gym tomorrow. You can have sex in a week. They're like, yeah, I'll take that. Retreatment, yes, you have to talk about retreatment rates. In Europe, the retreatment rate was about 30%. I will argue their technique, I think, was a little more lackadaisical from some of that data with only doing 3 blebs. And, I think we're doing more distally with the Bulkman now. So I think that's evolving. We need more data on what that true top-up rate is in practices. So we need more data. We need more long-term data, fair. And then they do mention this polyacrylamide hydrogel. We do have longer term data than our more stodgy bulking agents that we had prior to 2020 with FDA approval of Bulkamid in the United States. Absolutely lower satisfaction, lower efficacy than a sling. That is always something that should be disclosed to a patient in that shared decision-making process, lower success rate. But once again, it's about that risk-benefit ratio, which patients really are into these days, of what's the possible benefit, what's the risk profile, how does that ratio fit into my lifestyle? And no erosion risk, okay? Every patient Googles. They Google everything, and unfortunately, when you Google mesh sling, what you find out there, it's gonna scare you to not have it for a lot of patients, and then you lose them as a patient, and then they just go untreated. 5.4 million women are diagnosed with stress incontinence in the United States each year. How many get a procedure or surgery? 157,000. Okay, I don't think the other 4 million are being fixed by kegling their life away. Just gonna put that out there. Love PT, but I don't think that's our solution for the 4+ million other women with stress incontinence. So future directions in the guideline, yes. Informed consent, we need to be very honest in what we're presenting to the patient, the pros and cons with every treatment option in our toolbox. Super excited about stem cell injections. Hoping we keep getting somewhere with that. Excited to hear more about that today with another talk. We really do need to establish minimum standards regarding outcomes, and then also comparing outcomes. A lot of our data is a little old right now. Really appreciate Una Lee's work, where she is trying to grow that database. I think Seth Cohen, you're a part of that. Super good stuff. We need that. We need more of it, right? Let's keep building that denominator. And then this was the 2022 AUA State of Urology survey. They do it annually. It's really a great survey. I highly recommend reading these annually when they come out. They'll pick different topics, but this was done 2 years after Bulkamid got approved. And as you can see, slings certainly have the lion's share of stress incontinence treatments, but when we look at the data, we know the amount of slings being done is significantly been reduced since that FDA warning in 2011. What is interesting is that percentage of bulking agent being utilized more increased by 38%. So there's clearly a shift in the marketplace and availability of offerings. And I think a lot of us have really, there's been a resurgence in the use of bulking agents with Bulkamid because number one, it's a different substance. It's 97% water, it's very inert. It's a super easy talk track. Look, you put filler in your lips, I'm gonna put it in your urethra, and there's even a code that covers it. You're not gonna pay cash for it. And the delivery of it is different than what we were doing with old legacy bulking agents. And you can repeat it, and the scope works really nicely. There's a learning curve to this, but I think we can get a lot of women better with this treatment that were previously saying, no, thank you. So surgeon and patient perspective. I practiced in California for 10 years. I mean, the ladies out there, just everyone's in a different marketplace, but they just would not accept a sling. So many would say, no, thank you. And I also saw a lot of patients, so that talk track of, well, here's the special consent, and let's do another visit to talk about all the risks. It just wasn't efficient to even drive home these slings in patients. And then in 2020, it was so exciting to get Bulkamid because I didn't even know how well it could work in my practice, but I kind of went all in on it, and it was just awesome to start treating women and seeing good results, and it's just been a really satisfying ad in the last 4 years. I want to thank Angela there in the back for being a part of that. They really did an awesome job of launching this product, and it's been fun. It's been really fun. And it's great to just treat more patients. Okay, but once again, the reality, the satisfaction scores, they're a little lower. The dry rate, it's lower than a sling. The cure to improve rate, it's slightly lower. But what patients really latch on to is, I'm comfortable doing this, I'm willing to do this, and I'm actually willing to do it twice when I don't get the results that I wanted with the first injection. So once again, I'm all about just patients getting treated. And unfortunately, the sling rates, I think they're, for risk, are very acceptable to me, but they're not acceptable to a lot of patients that do their own research. So it's not about what we think, it's what they perceive. Payment. So the reality is slings pay better. That's always a work and play with how payments work out. But I will say this, For all the patients that say no thank you to a sling and you lose them as a patient, you lose a lot of extraneous revenue. For the patients that continue on with Bulkamid, then you get to treat their urgency, their GSM, their UTIs, and they like stick with you for all that other revenue potentially with that patient. So the life cycle of the patient doesn't end with, well, I'm gonna go home and think about that sling, and then they never come back. So just throwing that out there as devil's advocate. And the cost effectiveness, we're not there yet. For a study for this really to be cost effective, about 60% would need to be done in the office. And right now, roughly only about 10% are done in the office when we're thinking about just healthcare economics on a bigger scale. Okay, so final two slides. Ogg's paper that was done by a really robust, great group of pelvic floor surgeons. I think this is where we've landed so far. We can consider a bulking agent if they demonstrate stress incontinence. I'm not a big believer in testing women over treating women. Like, I don't think we need urodynamics and cysto and all these extra tests for these women. Do show me leakage. I have women, they're so nervous about even doing that with me. I say, look, go home, jump on a trampoline, send me a picture of your pad or underwear with a HIPAA-compliant email, and I'm good to go. Do we make men demonstrate erectile dysfunction in front of us before we give Viagra? We don't, right? So just throwing that out there, because these women are terrified to talk about this and get it treated. But once again, back to we need more data. Full disclosure, we may need to repeat this. You may go on to a sling, very fair. And I think a lot of us are really adopting this as a first-line treatment because we are just so excited to treat more women that say no thank you to a sling. And it's also a great option. I have ladies come in with sling failure, and I'm like, well, we can try this bulking agent. We don't have to get into that scarred tissue. And yeah, we can certainly be thinking about this more in specific populations like diabetics, neurogenic, between having babies. And then finally, Bulkamid or polyacrylamide hydrogel, we do have to acknowledge like their safety and durability. It's not that much greater than our legacy bulking agents, so we do need to really keep working on building that data set, because I think for a lot of us, like, we've just been super excited and appreciative to have this add to help more of our patients. That's it. Thank you.